Hello, my name is Mandy Chittum. This is my healthcare policy advocacy presentation for Class 505. The policy I've chosen is the West Virginia's Collaborative Agreement requirements for nurse practitioners at the state level. This policy was designed to ensure that patient safety was maintained by advanced practice registered nurses by mandating that they work under a physician's supervision when prescribing medications. This policy also aimed to standardize the prescriptive practices and maintains oversight by the West Virginia State Board of Nursing for registered nurses. This policy originated in the state of West Virginia under the state code of 30-7-15B. It requires that all APRNs are required to complete 45 contact hours in pharmacology, and they must also enter into a written collaboration agreement with the physician. This is so that they can obtain prescriptive authority under the West Virginia state law. It was shaped traditionally by other medical hierarchies because there were concerns about independent prescribing practices with APRNs. The West Virginia RN Board oversees the compliance and the licensing for this, and according to the 2014 Legislative Auditor's Report, there have been no public safety issues with APRN's practices for prescribing. The collaborative agreement requirement was formalized in the early 2000s. It had been updated twice in 2014 and also in 2016. This allows limited independent prescribing. With this policy, the APRN must be in this collaborative agreement for at least 3 years under the state law and the legislative agreement. The dissemination occurred through the West Virginia RN Board website with the professional nursing organizations and continuing education seminars. West Virginia also continues to rank among states with limited NP autonomies, with rural areas that face the most provider shortages. The national data shows that there have been no increase in adverse outcomes in the states that have full autonomy for nurse practitioners. The West Virginia Board of Examiners for RNs oversee this. They verify the collaborative agreements and oversee all licensing. When looking at the impact analysis using the Maycock, Howitt, and Sleevan advocacy model, I have identified 5 different areas to look at: the problem identification, the policy analysis, strategy development, and the action implementation and evaluation. With the problem identification, the collaborative agreement restricts the NP's autonomy, particularly in rural and underserved areas where physician collaborations may be unavailable. This limits access to care and delays treatment. This has been noted in the West Virginia Senate for 2014. The policy analysis shows evidence from states with the full nurse practitioner autonomy, such as Oregon and Colorado. This shows improved access to care, no increase in malpractice claims have been noted, and the cost-effective primary care delivery has been maintained, according to the AANP and the article noted. The strategy development shows that advocacy strategies include coalition building with nursing organizations. You have the legislative education campaigns and patient testimonials from underserved regions. With the action implementation, they have proposed legislative changes that would eliminate the mandatory collaborative agreements after a defined transition period, such as 1 year of supervised practice. With education, monitoring NP's workforce expansion and patient access metrics and prescribing safety data. All of this has been proven in other states, and the outcome has been positive. When looking at the effectiveness of this policy and certain changes, the policy has not been effectively addressed about the provider shortages. It also creates burdens for administration and limits what the NP can practice in high demand areas. While the policy was intended to ensure safety, data from other states show that NPs can safely and effectively prescribe independently with the proper training. In 2016, West Virginia allowed NPs to prescribe independently, but after 3 years, the collaborative practice. This still delays access, and it limits new graduates on where they can go and how they can practice. The current proposed change is that advocacy groups are pushing for full practice authority upon licensure. This is supported by the national trends and evidence-based outcomes. The proposed recommendations is to eliminate the mandatory collaborative agreement for newly licensed NPs and allow full practice authority with standardized pharmacology training. Although the state does require 45 hours in pharmacology, if this does go through with a change, the nurse practitioners may be seeing that as there's an increase to provide that training. 27 states now grant full practice authority to NPs. Rural health outcomes improved with NP-led care, and there have been no increase in adverse prescribing events in the autonomous states that already have full practice. The implications expand access to care, it reduces administrative barriers, and it empowers the nurse practitioners to serve underserved populations. Within the state of West Virginia, we have very many areas that have limited access to health care or the providers that they need to be seen by.